Hi everyone, I'm Dr. Nehal and today we are talking about mastocytosis. It will be covered based on the single term, that is mastocytosis. We will be using this particular terminology of mastocytosis and slowly building up the concept to cover the entire topic. So pay attention how this entire topic is covered by just this single term, that is mastocytosis. So first of all, let's break down this terminology of mastocytosis into two, that is masto, and the second one is cytosis. Okay, so masto comes from the word mast cells. Okay, and cytosis is nothing but increase. These mast cells, as you can see in the diagram, these mast cells, they are filled with granules. And these granules, they are of two types. They can either be preformed granules or they are granules that require activation. They require a trigger that will activate them. So the granules are of two types. The one are preformed and the second one is that they require trigger. So in preformed you have histamine, tryptase and heparin. So histamine, tryptase and heparin, they're already formed and they're stored in these granules. Whereas prostaglandins, leukotrienes and cytokines, these get formed, or these are formed upon activation of the mast cells by certain triggers. Okay, so mast cells are basically loaded with granules with this content. And if we look at the IHC, the immunohistochemical markers, there is CD34, CD117 and CD13. CD117 is also called as c-Kit, and as already mentioned, there is serum tryptase. Okay, so this was all about mast cells that we need to remember for this particular topic. Then coming up to cytosis. So cytosis is increase. So in mastocytosis there is increase in the number of mast cells. So there is increase, there is proliferation, there is excessive proliferation, and these cells on increasing and proliferation, they get accumulated in a particular place, and they get accumulated to such an extent that they will cause damage of the organ and lead to organ failure. Okay, so cytosis refers to increase in the number of cells, that is, there is proliferation, there is accumulation of them in a particular organ, and it causes organ damage and organ failure. So now, why does proliferation happen? Proliferation happens because there is increased production. So if anything is going on increasing, it could be either that there is increase in the number of it or it is not properly removed. So when it comes to increase in production, it is because of the mutation. Okay, which mutation? KIT mutation. So remember, we will study subsequently about MPN, and MPN are also the conditions where there is increase in the number of cells, and but mastocytosis is significant, or it is different from MPN, or based on the mutation that occurs. In MPN we have mostly the JAK2 mutation, whereas in mastocytosis we have the KIT mutation. So this KIT mutation is extremely important, and this KIT mutation is the one that causes increase in the number of mast cells. So which particularly, this is the most common, that is KIT D816V. KIT D816V mutation is the most common mutation, and this mutation leads to mastocytosis. Okay, so the codon 816 substitution of aspartic acid with valine causes KIT mutation. This mutation leads to proliferation of mast cells. Also, there is reduced removal, there is reduced apoptosis. Okay, so once there is mutation, it leads to clonal neoplastic proliferation of mast cells. Okay, so far so good. We have understood from the single word, we have arrived to this proliferation. Now we know that the mast cells are increasing, and where they will accumulate, in the place where they will accumulate, they will cause the symptoms accordingly. Okay, so depending on the location where they will accumulate, they will cause symptoms. Basically, we have broadly divided it as cutaneous and systemic. Alright. So first coming up to cutaneous. Now in cutaneous we know skin lesions, they can either be a normal rash or it can be a localized lesion, or it could be a diffuse lesion, which is, not just a rash, but it is widespread. So based on these three exactly, the cutaneous lesions have been further classified here. That is just a rash, that is urticaria pigmentosa. Remember, urticaria is something that is always synonymous with a rash. So urticaria pigmentosa is number one. Number two is mastocytoma of the skin. That is, it is a localized lesion. One localized lesion, mastocytoma of the skin. The third one is diffuse cutaneous mastocytoma. Alright, so we have urticaria pigmentosa, mastocytoma, that is a localized lesion, and a diffuse lesion. So till now we understood that there is proliferation of mast cells and what is happening when they are getting accumulated in the skin and causing these cutaneous symptoms. Now, one common thing that we see in all the cutaneous lesions is that it occurs in children. It occurs in children. So C for C for cutaneous, C for children. So they are most commonly seen in children. Okay. Now coming up to the first one, that is urticaria pigmentosa. It is a rash. Yes, we already know that. It is seen in children. We know that too. There is mast cell aggregation up to the papillary dermis. So it is pretty superficial, So it is only till the papillary dermis and the periadnexal and perivascular spaces. So by far we understood urticaria pigmentosa well. Now let's move on to the second one, that is mastocytoma of the skin, which is localized. So this is a single lesion, yes, because it is localized. We know that it is seen in children. There is no atypia, and even this is seen up to the papillary dermis. So mastocytoma of the skin also done. Now the third one, that is diffuse. Diffuse cutaneous mastocytoma. It is also seen in children. Yes, we know that. We have a band-like infiltrate because it is diffuse, it is coming down. So it is more than a rash, it is not so superficial, it is pretty deep. And how deep? There is a band-like infiltrate. Okay, and it is often called as grain leather appearance because it is so thick, it looks like leather. Alright, so this was about the cutaneous symptoms of mastocytoma. Now coming up to systemic. So when mast cells were getting accumulated in the skin, it was giving rise to cutaneous symptoms. Now it is going to the organs and it is causing systemic manifestations. Now what are the certain common things that we see in systemic mastocytosis? Mnemonic A, B, C, D. A, it is seen in adults. We saw that cutaneous, C for C, occurs in children. Systemic occurs in adults. It involves the bone marrow. Okay, and there are constitutional symptoms, and there are symptoms which there is damage to the organ. There is damage to the organ, and E, it's most commonly associated with eosinophilia. So it occurs in adults, bone marrow involvement is present, constitutional symptoms are there, damage to the organ, and last one, eosinophilia. So eosinophilia is one of the common findings. Now, so for systemic mastocytosis, WHO has given a criteria, and this is the criteria that WHO has given. And there's no harm in reading the criteria and going ahead with it, but the problem is that during exams it might take you a while to remember it. So to ease your apprehension, I have used a small story and a comic here which will tell you how to remember this measure and. So this is Sam, and he is 25 years old, and he is offering you two things. He is offering you two offers, and you can choose between the two. So the first offer is he's saying that he has 15 good flowers. So these flowers are fresh, they are of all equal sizes, they are good. So either you can buy flowers which are 15 good flowers, or he is giving you a second offer. He is offering you that the flowers are not so good. Okay, they are not of equal sizes. Some is big, some is small. They are not of equal sizes. So instead of giving you 15, he is giving you 25 of them. He is giving you 25 of them. Plus he is giving you this particular kit. Okay, and to compensate for those not so good flowers, he is giving you 25. He is giving you kit, plus he is giving you a drink. Okay, now so CD25 positive, and this surprise kit has a diary. It has a diary which is having 816 pages. Okay, so the surprise kit is having a diary which is having 816 pages, and there is a drink, okay, which is having 20 ml of juice. So there are two offers that Sam has to offer to you. That is, one is either you buy 15 good flowers or you buy not so good flowers. So to compensate that, he's giving you 25 to them because he's 25 years old, and he's giving you a surprise kit which has a diary and which is having 816 pages, and he's also offering you a drink which is 20 ml. Okay, so now let's read the criteria. So we have the major criteria. So the major criteria is more than 15 cell aggregates. So the 15 flowers are more than 15 mast cell aggregates, more than 15 mast cell aggregates in bone marrow or in the extracutaneous organ. So that is the major criteria. The minor criteria is that there should be more than 25% mast cells which are atypical or immature. More than 25% mast cells which are atypical or immature, and they are CD25 positive. His age is 25, so everything is correlating with 25. And the kit, the surprise kit, is nothing but the kit mutation, which is having a diary, D for diary, which is having 816 pages. Along with that, he is offering you the drink, that is serum tryptase, which is more than 20 nanogram per ml. So with help of this story, you can remember this criteria. And once the diagnosis of systemic mastocytosis is done with the help of this criteria, you can move to the subclassification. So now in the subclassification, there is B and C findings. B is the burden of the disease, and C is the ones requiring cytoreduction. Okay. So for B findings, we have B bone marrow more than 30% should be mast cells. Okay, bone marrow more than 30% should be mast cells. There is dysplasia. There is hepatosplenomegaly. Hepatosplenomegaly without the symptoms of liver impairment. There is no liver impairment, and without hypersplenism. Also, there is lymphadenopathy. So there is basically all the organs are getting involved. So the organ symptoms, that is bone marrow involvement. So bone marrow involvement, so more than 30% of them, the cells should be mast cells. They should also have dysplasia, hepatosplenomegaly without liver impairment and without hypersplenism and lymphadenopathy. And then we have the C findings. In C findings is there should be cytopenias. Now what happens is that the mast cells, they will proliferate to such an extent that they suppress one or the other lineage. And if they are suppressing some lineage, it will lead to cytopenia. So that basically shows that the bone marrow is not functioning properly. So C, there is cytopenia. Remember, B say you start with bone marrow, C say you start with cytopenia. And then there is skeletal involvement. Here we covered hepatosplenomegaly. Here also we have hepatomegaly, splenomegaly, but it is palpable. And there is also bone involvement, that is, there is skeletal involvement and osteolytic lesions. Okay, so far so good. If we just take a moment to look back, we have mastocytosis coming from mast cells, mast cell proliferation. How the proliferation is occurring, we have seen, and depending on where it is occurring, we have the cutaneous mastocytosis and systemic mastocytosis. We also studied about the different criteria and the B and C findings. Now, the systemic mastocytosis has been divided into indolent, smoldering, aggressive, with hematological malignancies, mast cell leukemia, and also mast cell sarcoma. Okay, so we have indolence, smoldering, aggressive, then associated with different hematological malignancies, mast cell leukemia, and mast cell sarcoma. So the first one is indolent. Now I have grouped all of them together into different columns, that is indolent, smoldering, aggressive, associated with hematological malignancy, and then is leukemia. So first we begin with, in purple, I have mentioned for all of them what is the status of mast cell. So since we are talking about mastocytosis, we will start with mast cell. So mast cell burden, MCB, is mast cell burden. So in indolent, it is a very benign, it is near to benign, so it is low. So the mast cell burden will be low. Here in smoldering, the mast cell burden is high, and in aggressive, it's obviously high. Then in mast cell leukemia, it is basically systemic mastocytosis, and you have a leukemic variant. Okay, and we'll talk about that ahead. Then in blue, we will talk about the clinical features. Now, we saw that cutaneous mastocytosis was most commonly seen in children, but it can be seen in adults as well. So, depending on the burden of the disease, if it is less, then skin lesions will be seen. So, skin lesions are seen in indolent. It is also seen in smoldering. It is not seen in aggressive. Okay, as the tumor burden or the disease burden increases, it will skin lesions will not be seen. More organ involvement, less skin involvement. So for smoldering there is organ involvement, and for aggressive also there is organ involvement. So first we are done with mast cell burden, then we are done with skin lesions and organ involvement. Then we have the WHO criteria. So there is WHO criteria plus there is one B finding for indolent. We already spoke about the B finding. They are a pretty benign sort of findings, that is, there is hepatomegaly, splenomegaly, but no impairment. So WHO criteria plus 1B finding is for indolent. WHO criteria plus more than 1B finding is for smoldering, and WHO criteria plus more than 1B plus more than 1C makes it aggressive. Okay, this is like pretty understood. You first talk about the mast cells, then you talk about the skin lesions and the organ involvement, then you talk about the WHO criteria in the same order as we have studied. Then the bone marrow involvement. The bone marrow involvement should be less than 20% of all nucleated cells in aggressive. Okay, because if it becomes more than 20%, it will be categorized into mast cell leukemia. Okay, and this aggressive is going to go and turn into mast cell leukemia. So there are two variants. There is a classic variant and there is a leukemic variant. In the classic variant, there are more than 10% of mast cells which are present on the peripheral smear, and here it is less than 10%. Okay, so there are two variants. Then talking about the association with hematological neoplasms. Now there is the most common one is CMML. Then we have MDS, MPN and AML. Now one thing to remember is that I told you, while talking about the mutation in mastocytosis MPN, how it is similar. So the mutation is one that makes it different, but when there are more than one mutations and there is like the tumor burden increases, there are different associated malignancies as well. So the most common one is CMML, MDS, MPN and AML. Now talking about mast cell sarcoma, it is also called as malignant mastocytoma, and there are obviously atypical mast cells are there. There is presence of TET2 mutation, CD25, CD30, CD117, CD33, CD43 positive. CD25 we already know. CD30 positivity is important. It is also been included in the latest WHO, the one which is proposed. We'll talk about that too. And there is CD117 positive, which is KIT mutation, as already mentioned before. So this is about mast cell sarcoma. Now let's talk about the investigation. So investigations are straightforward. We need to do CBC, LFT, serum tryptase. We need to check for the levels of CD25, CD117. Certain radiological findings such as abdominal USG, CT scan for hepatosplenomegaly. For bony lesions, we need X-ray. Biopsy is also required, skin biopsy as well as wherever the organ involvement is present. Along with that, we need bone marrow studies, both aspiration and biopsy, and we can do IHC for anti-tryptase. Alright, so this was all about mastocytosis. I'd like to mention what has been added in the latest WHO classification, the proposed WHO. The diagnostic criteria have been refined to CD30 and any KIT mutation are introduced as a minor diagnostic criteria. So in the story we spoke about that he was giving two offerings. So one was the major, that is more than 15 cells, and the second one was that he is giving you more than 25 cells. So in that minor criteria, we will need to add CD30 also, and any KIT mutation. So he was giving you basically a diary which was having 816 pages, right? So this diary can be any diary, it can have any number of pages. So CD30 and any KIT mutation is present in the minor diagnostic criteria. And there is a new entity, that is bone marrow mastocytosis. We spoke about all the entities here. These entities: indolent, smoldering, aggressive, mast cell leukemia. So this is bone marrow mastocytosis, is a new systemic mastocytosis subtype. Also, the KIT 816 mutation with a VAF of more than 10 qualifies as B findings. So we spoke about a lot of B findings, right? So in the B findings, we have to even mention about this, that is 816 mutation, which has a VAF of more than 10%. So what is VAF? VAF. So VAF is basically a variant allele frequency. Okay, so variant allele frequency, what does it tell? It tells about the estimate. It gives you an estimate of the proportion of mutated cells. So it gives you an idea about the tumor load, the disease burden. It is like the proportion of mutated cells. So if VAF is more than 10% related to 816 mutation, it has to be added in the B findings, right? So B findings, you remember we started with bone marrow, then dysplasia, then hepatosplenomegaly without hypersplenism and without liver impairment and lymphadenopathy. So in that you have to even add this, that there is KIT 816V mutation with VAF 10%. I basically kept this different and not added in the criteria because there are questions which are asked specifically what are the newer changes. So when there are newer changes, you need to mention these. Okay, so these are the newer changes. Now let's finally conclude this with an approach to mastocytosis. Okay, so basically what we have the mast cell infiltrates, and these infiltrates, they could be present in a child or they could be present in an adult. So most commonly in child, we've already said that there is cutaneous lesions. So it's, if there are, we check for any signs, if there are any signs of systemic disease. If there are any signs, if there are no signs, good, it is cutaneous. If there are signs, yes, then we need to do further workup. And for adults also, you need to do further workup. All right, so what is the, first we'll finish this. So there are no signs, right? There are no systemic signs, then we will do serum tryptase. Serum tryptase, if it is less than 20, then it is childhood cutaneous mastocytosis. Okay, if it is somewhere between 20 to 100, then it is mastocytosis of skin. If it is more than 100, then then we need to go for additional workup as said here. Okay, so what is the additional workup? We will see the KIT mutation. We will see the KIT mutation. We will do CD2, CD25 expression, and we will do the bone marrow biopsy. So if we will see for the criteria, the SM criteria, that is systemic mastocytosis WHO criteria. If it is fulfilled, if all the points are tick mark, one major plus one minor or more than three minor, then it is your systemic mastocytosis. If not, it is still a cutaneous mastocytosis, which will require close follow-up. And that's it. Okay, so this is the approach to mastocytosis. So thank you everyone.